Good day, I'm John P. Espejo, a clinical clerk from Cebu Institute of Medicine. In this video, I'll be demonstrating the procedure of open tracheostomy using improvised materials. Open tracheostomy is the creation of communication between the trachea and the overlying skin. It is indicated for airway obstruction, respiratory support, pulmonary hygiene, elimination of dead space, and for the treatment of obstructive sleep apnea. Materials needed are scalpel blade with holder, forceps, retractors, scissors, cautery, suction, gauze pad, needle and suture, tracheostomy tube with ties, local anesthetic, and syringe. Place the patient in a supine position with the neck extended by a pillow placed under the shoulders to give adequate access to the cervical trachea. Identify the incision site by palpating the important surface landmarks. This includes the thyroid cartilage notch, the cricoid cartilage, and the sternal notch. Mark the incision site 2 cm or 2 finger breadths above the sternal notch and the skin crease. Traversed during tracheostomy are the skin, subcutaneous fascia, sometimes platysma, investing layer of the deep cervical fascia, strap muscles, pretracheal fascia, thyroid gland, and the tracheal rings. Sterilize the skin of the anterior neck and chest and drape the neck accordingly. Unless the patient can be safely intubated or can be ventilated with a mask, a tracheostomy should be done under local anesthesia. Make a horizontal incision, which is cosmetically preferred than a vertical midline incision. Extend the incision to the skin and subcutaneous tissue and the platysma at times, although it is generally absent at the midline. Take care not to transect the anterior jugular veins, which are just superficial to the strap muscles within the investing cervical fascia. They can be preserved and retracted laterally. Retract the tissues with Sen retractors. The subcutaneous tissue can also be dissected using the cautery. Divide the fascia with scissors, remaining strictly on the midline in a vertical plane to avoid injury to the inferior thyroid veins. Intermittent palpation of the airway can be done to check if it's deviated from the midline. Once the fascia has been cleared, identify the strap muscles and retract them laterally. Divide this intermuscular plane by spreading with a pair of scissors. Sometimes, the isthmus of the thyroid is encountered over the second and third tracheal rings. Retract the isthmus superiorly with a Langenbach retractor to expose the trachea. The trachea and cricoid can now be palpated. Divide the pretracheal fascia with a pair of scissors. Once the airway is identified, communicate with the anesthesia provider to confirm the safe FiO2 level. At this point, deflate the cuff and advance the tube and reinflate to avoid puncture of the endotracheal tube. Also, ensure that the surgical field is completely dry before proceeding, as it is difficult to achieve hemostasis once tracheostomy tube has been inserted. The tracheotomy is made between the second and third tracheal rings. Blood is suctioned away for better visualization. A Bjork flap is made to help with tracheostomy tube changes. This is done by cutting the third and fourth tracheal rings to create a big flap. This is sutured with a chromic stitch to the skin. To safely secure the stitch, make sure that you're suturing from underneath the cartilaginous tracheal ring. It is important to communicate with the anesthesia provider again at this point to deflate the cuff, pull the ET tube back until the tip is in view. The appropriate size tracheostomy tube is then inserted, the obturator is removed, and the inner cannula placed. Patient is then reconnected to the ventilator. The tracheostomy tube cuff is inflated. Confirm tracheostomy tube placement in the airway with the end-tidal CO2 level and listening for breath sounds and observing for adequate chest rise. Secure the tube with sutures but not too tightly because it can cause surgical emphysema. Further secure with tracheostomy tube ties but not placed too tightly. Immediate complications include bleeding, subcutaneous emphysema, perforation, vocal cord injury, recurrent laryngeal nerve injury, and pneumothorax. Early complications include infection, decannulation, and obstruction from secretions. And lastly, late complications include dysphonia, scarring, stenosis, fistulas, and tracheomalacia. Thank you for watching.